Good evening, everyone. A warm welcome to all the doctors and patients who have joined today's session. I am Ami from Antardhwani. It is a joint initiative by Antardhwani and Indian Rheumatology Association to have with us eminent Dr. Nijil Haroon. He is the Vice President, Canadian Rheumatology Association and Associate Professor, University of Toronto. We have with us Professor Dr. 𝐊𝐞𝐲 𝐭𝐬. He is the President, Indian Rheumatology Association and Head of Department Rheumatology, Government Medical College, Kolkata. And we have Dr. Sapan Pandya with us. He is the Secretary President, Indian Rheumatology Association and Professor of NHL Medical College and SVP Hospital in Ahmedabad. It is a kind request to all the participants to please mute yourself during the session. If you have any questions or queries, please feel free to write in the chat box. We will try to ensure that all your questions and queries have been answered. And in case if something is left out, we will try to answer it over the email. It is a humble request to all the participants. Do not ask questions related to personal medical treatment or medications. They will not be answered during the session. Tapan sir, all yours.
Thank you. Good evening, everyone. And so I must, with a request that everyone keep your, audios muted, because this is what happens, and we were really worried about that. This is the first of its kind of ankylosing spondylitis patient support group meet in the country. So we are very proud of that. Antardhwani is the organization which has initiated this, and if Mr. Praneeth Bhantia can raise his hand, then people will know him. He is the person. He owns High-Tech, a company, which that is the way we started, and gathering patients. And he was the one who, then he has a team of people. So there's a whole team of people who is working on it. Antardhwani has been doing various kinds of, we have had many patient support group meetings with mostly rheumatologists from Gujarat. Couple of times we've had people coming from outside also and speaking to patients. We've done live sessions, and we've done recently in the last 3 months, we've had Zoom sessions also. And then we have had various, we've done camps also a couple of times, organized camps in Ahmedabad and other places, mostly in Gujarat again. Dr. 𝐊𝐞𝐲, Professor 𝐊𝐞𝐲 sir has the lupus foundation there. There's one in Karnataka. So the patient support groups are slowly picking up in India. The other thing is that we've done some specialist meetings, like we had one meeting with a gastroenterologist, we had one meeting with the yoga specialist recently. So even the allied specialists, we are having, Antardhwani has been doing this kind of work for the last 3-4 months. And the best part is, the last time, I think they also questionnaire, which they've had patients to answer. So now we are starting with some kind of research, and we hope that patients will slowly we'll get into that mode of also knowing about what the problems of the patients are through questionnaires. And the last, of course, is to educate, since we have so many patients. And in India, while we have still not reached those levels, I'm sure Nijil will probably say that, and Professor 𝐊𝐞𝐲 has been always advocating that, is that in most of these countries, now patients are members of the advisory group, the people who make the guidelines for treatment also. So, we need to reach those levels of scientific temperament in our country, where we have representatives from patients who are there in the group that makes the guidelines for the disease for the country. Because it is finally you people, the patients who are suffering. Whatever we do, whatever I say, whatever Nijil says, Professor 𝐊𝐞𝐲 says, we really don't suffer from the disease. So you have to have at least one person or 2 people or 3 people, preferably from different zones of the country, who are sort of patient leaders. So that is something we need to mature into. After the Antardhwani, the other thing about Professor 𝐊𝐞𝐲 𝐭𝐬 has already been introduced by Ami. He is our president of the Indian Rheumatology Association at the moment. He comes from Kolkata Medical College. He's been a professor for many years. He, as you will see, he has a wonderful temperament. He has a very good team of his students who works on this. And Professor 𝐊𝐞𝐲 and our team of the Executive Committee of the Indian Rheumatology Association had decided, and we had funds also for doing a lot of programs throughout the country. And while the first or second one was planned, the date was fixed and the lockdown occurred. So that was very unfortunate, but we have a plan of doing patient support group sessions throughout the country in different diseases, not just ankylosing. But so that is one thing that the IRA is going to initiate. I'm sure Professor 𝐊𝐞𝐲 will speak a little bit about that. And then we also plan to make pamphlets for patient information, which we have. I would request all of you to go through the Indian Rheumatology Association website. All you have to do is to Google Indian Rheumatology Association, and you will find our website. Just log into the website, and there is a patient corner there. It reads that there is a patient corner, there is a members corner. So those who are members of IRA have to need a password, but the rest of them can actually have a look at a whole lot of things which are there. And we also have information on ankylosing spondylitis, or we'll be putting up more information soon. Also details about COVID in case you want to know about COVID, what is happening in COVID, and what are your problems with COVID, what are the drugs you should take. So we have that corner also. So I request all of you to go through that. So that's about the Indian Rheumatology Association. Lastly, Nigel, of course, is the star of this show. You know, every show has either an Amitabh Bachchan or a Shah Rukh Khan who's there. So Nigel is easily our Amitabh Bachchan and Shah Rukh Khan. I sincerely must thank Rijal for coming and joining. I know his time is so very important, and when he's so very busy that giving 1 hour to our patients, you know, which doctors ko to hamesha dete hi hain, but this is for patients. I think we must thank him profusely for that. I know each bit of this is very important. He was with us. We were lucky. I was not lucky to be with him when he was in Lucknow, but he came after me. So he passed out as DM from Lucknow and then went to Canada. He's in the University of Toronto, and he's easily one of the international leads in ankylosing spondylitis. It is very easy to find out. Just Google Nigel Harun and you will have what kind of publications he has. He's worked on one particular gene for ankylosing spondylitis. I won't go to the technical details. He will probably simplify for us. And he's done some original work on that. I think all of you should be ready to bombard all kind of questions you want on the chat. I will go through your questions and I'll put them to Nigel so that, you know, they can be filtered, because there might be some repetition. That is the way we will go. That is the way we'll go. I think with that, I'd like to end my part. I'll come with the questions later on. We'll first have Professor 𝐊𝐞𝐲 speak on ankylosing spondylitis general, and then we'll have Nigel speaking on the cause of the disease in a simple manner and what the future lies. And after the two talks, we'll have the question answer session, but everybody can ask starting questions and put them in the chat group so that by the time we end, we have questions which are ready. Thank you. Thank you, Ami.
Thank you, sir. Dr. 𝐊𝐞𝐲?
Yeah. Thanks, Saban, for the wonderful introduction. Indian Rheumatology Association is already planned, as Shapan has already initiated, that we need to have patient support group, because science on the one hand in rheumatology practice and the art of delivering that practice, and ultimately the patient who matters, and our components of science should percolate through us in the peripheral part as well to each and every patient who matters. And we have already planned, but unfortunately due to these prevailing situation, we could not initiate. But this is a wonderful initiative from Shapan, who take all responsibility, and Antardhwani is there. And we are really lucky to have Nigel with us and on this topic, ankylosing spondylitis. And whenever I had a talk with Ramnath, and whenever he gave the opportunity to talk about Nigel details, so what a pleasure to have Nigel with us here. So Nigel, welcome. So regarding ankylosing spondylitis, it's really matters for the young, productive, young people, male, around 25, 30s, like that one. And the primary concern is the pain, and predominantly the back pain. And that back pain, interestingly, involves more during rest. So night become nightmare. And whenever patient has got this experience, he always feel when the night will end, when the day will start, and he would be having his activities of daily living, gradually it is being compromised. And the usual dictum was that the patient takes nearly 6 to 7 years to present to the clinician. But interestingly, due to some sorts of awareness throughout the country, in our part, we are getting patients having symptoms hardly even 3 months disease duration we are getting. So patients, if they can present to the clinician with a characteristic pain with stiffness, predominantly in the back, usually lower back, improves with activities but not with rest, and this pain and stiffness usually involves the second half of night, not the first half. So patient goes to bed comfortably. In the midnight, whenever trying to change his or her posture, there is a pain and stiffness, awakening him or her, and taking 1 or 2 NSAIDs like that one. And NSAIDs, the painkiller, it's a very interesting medication for ankylosing spondylitis is that it's not only relieving pain, but it has got also disease modification modalities, mechanism of action. And whenever a 25-year male who has diagnosed to have back pain with a characteristic diagnosis of ankylosing spondylitis takes NSAID for some period, getting relief. So first and foremost, whenever we have a pain and stiffness involving the back, and this pain is more with rest than improves with exercise, and there is good response to NSAID, that suggests more towards the diagnosis of ankylosing spondylitis. Usually male preponderance, less of female, but we are getting female patients nowadays with ankylosing spondylitis. So in our younger days, that 9:1 or 8:1, something like that was the ratio. Now gradually ratio is gradually changing and moving more towards clinical presentation involving the female as well. There is an entity called non-radiographic spondyloarthritis, more of female, 50% may not have the genetic association, but there are literature which are coming, and possibly it's not a different entity, it's a part of ankylosing spondylitis, and it's not the non-radiographic, but possibly pre-radiographic. So there's some semantics issues are there. Nigel can come up with the scientific components that one, what needs to be addressed. So when the clinical suggestion is there, so the primary investigation is not the HLA-B27. One should keep in the mind that HLA-B27 positivity is not equivalent to the diagnosis of ankylosing spondylitis. If we pick up 100 HLA-B27 positive, but interestingly, 100 ankylosing spondylitis, 75 to 90% would be having HLA-B27 positive. So that is the connotation of HLA-B27. So when a patient is having a back pain, one should not immediately ask for B27. And positive B27 is not equivalent to ankylosing spondylitis, one should remember. So first investigation, if we plan to do for an ankylosing spondylitis, is a plain X-ray, digital X-ray pelvis at anterior oblique view, right and left, which can demonstrate sacroiliitis, which is the hallmark of inflammation primarily involving sacroiliac joint, which is the main initial pathogenic issues for ankylosing spondylitis. And there is raised TNF alpha there, which has been documented, and TNF inhibitor are the primary management modalities, as we'll talk. So after having the X-ray, if we document sacroiliitis with a characteristic inflammatory back pain, less than 45 years, and it's a less than 3 months duration, the primary constituents for the diagnosis is being fulfilled, and one can move towards the final issue, anything to be done or not. So when one should ask for HLA-B27 in a given patient who is having a back pain, so when X-ray doesn't show any abnormality and characteristic inflammatory back pain, so one should then check the checklist of 2009 ASAS criteria, where there are other spondyloarthropathic components like reactive arthritis, like skin changes, like eye redness, anterior uveitis, like IBD, like psoriasis. So if out of these 10 or 11, if more than 4 is there, one won't require B27. If it's 2 to 4 with a characteristic back pain, with a negative X-ray, one can ask for B27. But with a less than 1, one can ask for B27. If it's a negative, then one can plan for MRI. So primary investigation is X-ray pelvis, followed by HLA-B27 in specific subset, followed by MRI, very small subset of patients. But if we have patient who has got a characteristic inflammatory back pain, if you have got negative X-ray with a negative B27, one can ask for MRI. And if the disease duration is very short, like less than 6 weeks, 3 months, something like that, and if we need to address the early diagnosis, which would help the change of the outcome with therapeutic intervention, so we can ask for MRI to document sacroiliitis. And this is the entity which comes under the heading of non-radiographic spondyloarthritis. So patient is having inflammatory back pain, X-ray negative, MRI positive, usually female preponderance, usually B27 negative, half of the patients, and patient's outcome is reasonably better in comparison to Ankylosing. But what's about the outcome of Ankylosing? If it's diagnosed early, proper time, initiated, and patient has got an hereditary history, usually half of the patients can have a characteristic history. If the first order sibling can have a chance of having 30 to 40% having ankylosing spondylitis, if father or mother has gotten B27 positive SPA group. So the therapy should initiate at 50%, half if we divide it those two components. Half of them, certainly, most important part is exercise. And out of this exercise, swimming, as we always tell, otherwise free hand exercise, running, jogging, and at least 30 to 40 minutes, regular exercise. That keeps the man of ankylosing spondylitis reasonably stable, even with a minimal pharmacotherapeutic requirements. Followed by NSAID, and this NSAID, whatever way we feel like, but usually in our practice, we start with etotoxin, 60 or 90 milligram a day, and can be continued up to 6 months to 2 years. That's an issue. Painkiller, should we take this regularly? That's the main concern for the patient. But young patient having no comorbidity, not a smoker, because smoking is a very important precipitating factor in ankylosing spondylitis, just like COPD, bronchial asthma, lung cancer. So ankylosing spondylitis patient from the day one, if it's a smoker, should quit smoking. And smoking, if it's not there, not a non-alcoholic, not taking any aspirin or other, regular intake of NSAID possibly help him not only to get rid of the pain, but to have a disease modification in terms of, because the disease would be having a two components. One is bone proliferation. There is new bone proliferation called syndesmophytes in the spine. And as has been documented in literature, that this NSAID will take care of this signal syndesmophyte formation. So there will be inhibition or prohibition of development or progression of syndesmophytes in ankylosing spondylitis patient. So with the initiation of NSAID, the patient will get relief of pain, patient will have an underlying modification of disease with a reasonable control of syndesmophytes progression, and which possibly is not being achieved with TNF inhibitor. But there are literatures coming that TNF inhibitor for long period, so it also may inhibit syndesmophytes formation. So this is the thing in nutshell in reference to ankylosing spondylitis, the spectrum. So whenever a patient is having a back pain, which is more at rest, improves with exercise, should visit physician to have an X-ray to document sacroiliitis, no recurrent of B27 in all patients, and HLA-B27 is not synonymous with Ankylosing. And for extraarticular manifestations, of course, eye is one of the very important components. 40 to 50% can have anterior uveitis, acute anterior uveitis, and which may require regular medication. And interestingly, ophthalmologists nowadays referring those patients who is having acute anterior uveitis, B27 positive, no back pain. Even after doing X-ray, it's negative. So these patients are being referred to us. So they would require not only regular eye care, but also the sulfasalazine or methotrexate, even in absence of arthritis, can take care of acute anterior uveitis. And TNF inhibitor, especially adalimumab, has been documented to have an enough evidence to control, to have a therapeutic effect. So this is one issue. Another is psoriatic arthritis. We are not discussing this one today. And the other parts are very minor. So this extraarticular also for eye, one should take care. So I think these are the issues, and regular monitoring with an exercise with a minimal NSAID once or twice a week patient can have a reasonably normal, happy and healthy life. I think these are the issues one should keep at the back of our mind after being diagnosed as ankylosing spondylitis, and we can have a happy, normal life with ankylosing spondylitis. Even marital life we take in normally, and there is no issues. Only issue is this genetic transmission that can be discussed straight away with the patient, and patient can have a comfortable one. So I think these are the issues, primary issue we can take care in reference to ankylosing spondylitis. Over to Shapon, yeah.
Yeah, Professor 𝐊𝐿𝐞𝐲, I think there is the request from quite a few if we can have a bit of it in Hindi. So you still have 10 minutes of time from your this thing. So can you say about 10 important things in Hindi to all
Hindi mein?
Yeah.
Okay. अच्छा, I will try. So it's a ये तो young patient लोगों को होता है, around 25 to 40 ऐसा ही होता है. Predominantly male ऐसा ही दिखा हुआ है. Female को आजकल तो हम लोग मिलते हैं female patient को, लेकिन one group जिसको हम लोग बताते हैं scientifically, it's a non-radiographic spondyloarthritis. It's a female preponderance. और ये HLA-B27 जो जीन मार्कर है, जेनेटिक मार्कर, उसके लिए मेल को तो हम लोग को मिलते हैं जो एंकाइलोसिंग स्पॉन्डिलाइटिस डायग्नोसिस होने के बाद अराउंड 75% to 90% पेशेंट लोगों को पॉजिटिव मिलता है. बट वन शुड रिमेंबर दैट HLA-B27 मिलने का बाद इट इज नॉट इक्विवेलेंट. ऐसा नहीं है कि B27 मिल गया, पॉजिटिव है तो हमारा एंकाइलोसिंग स्पॉन्डिलाइटिस हो गया और फ्यूचर में होगा. ऐसा ही दिखा हुआ क्या, हम लोग पॉपुलेशन से 100 नॉर्मल परसेंट चुन लिया, उन लोगों को B27 पॉजिटिव है. हार्डली 2 लोगों को आउट ऑफ 100 एंकाइलोसिंग स्पॉन्डिलाइटिस होगा. सो बाकी 98% जो आदमी है जिन लोगों का B27 पॉजिटिव मिला, कोई एंकाइलोसिंग स्पॉन्डिलाइटिस है ही नहीं. सो कोई ऐसा कुछ बात है ही नहीं. जब HLA-B27 कोई बैक पेन में HLA-B27 पॉजिटिव आ गया तो हमारा एंकाइलोसिंग स्पॉन्डिलाइटिस डायग्नोसिस हुआ, ऐसा नहीं है. जो डायग्नोसिस के बारे में हम लोगों का जो बैक पेन होगा, बैक पेन मोर एट रेस्ट, रात में ही ज्यादा होता है. जब हम लोग एक्टिविटीज में सुबह से चालू कर देते हैं एकदम अच्छा हो जाता है. और सुबह एक्सरसाइज वही है, एकदम बहुत जरूरी है, वेरी इंपॉर्टेंट ट्रीटमेंट है. तो हम लोग सोचेंगे, हम लोग प्लान करेंगे कि wherever in the world I am staying, हम लोग एक्सरसाइज कभी नहीं भूलेंगे. और उसके साथ साथ दवाई के बारे में जो हम लोगों ने बताया है, जो एंटी इंफ्लेमेटरी ड्रग्स, वो जो पेन किलर जो है, ये वाला पेन किलर खाली पेन रिलीफ होता है ऐसा नहीं है. ये पेन रिलीफ होने का साथ साथ वो डिजीज का भी एड्रेस करते हैं. क्या करते हैं ना, एंकाइलोसिंग स्पॉन्डिलाइटिस एक अलग इशू है कि बोन फॉर्मेशन हो जाता है. ये जब डिजीज प्रोग्रेस करते हैं, अल्टीमेटली हम लोग बताते हैं, ऑल ऑफ अस हैव एक्सपीरियंस, बम्बू स्पाइन, एकदम जो बैक एकदम स्टीप हो जाता है, खड़ा हो जाता है, बम्बू का माफिक कैन नॉट फिक्स, सामने झुकना बहुत डिफिकल्ट हो जाता है, साइड मूवमेंट बहुत डिफिकल्ट हो जाता है. ये इसके लिए हम लोग फ्रॉम द बिगिनिंग हम लोग एक्सरसाइज चालू करेंगे, हम लोग एंटी इंफ्लेमेटरी ड्रग इनिशिएट करेंगे, तो वी कैन हैव ए वेरी हैप्पी एंड हेल्दी आउटकम. डिजीज बहुत कंट्रोल में रहता है. उसके साथ साथ आजकल तो ये जो बायोलॉजिक्स मिल गया TNF इनहिबिटर, तो उसके लिए वंडरफुल रेस्पॉन्स, बहुत अच्छा रिस्पॉन्स होता है. लेकिन 2 इश्यूज आर देयर, वन इज कॉस्ट, वन इज कॉम्प्लिकेशन, इन्फेक्शन. सो कॉस्ट का बारे में आजकल कोई स्टेट में तो गवर्नमेंट हॉस्पिटल से फ्री मिलते हैं, अदरवाइज तो बहुत सारी बायोसिमिलर. सो इनिशियली एक ही कंपनी बनाते थे, आजकल तो बहुत सारी कंपनी आ गया, सो इसके लिए कॉस्ट बहुत कम हो गया. But the another part is infection, chance of having reactivation of infection. अंदर में कोई टीबी का खास जाड़ में रह गया है, बिकॉज हम लोगों का सोसाइटी में टीबी का प्रिवेलेंस ज्यादा ही है. सो हम लोगों का एवरी चांस इज दैट कि हम लोगों के अंदर में टीबी का कुछ ना कुछ बैसिलस है, तो वो डोरमेंट है. तो TNF इनहिबिटर देने के बाद वो आ जाता है, टीबी का बीमारी भी पकड़ा जाता है. ऐसा ही दिखा हुआ है हम लोगों ने. सो हम लोग प्लान करते हैं, सो वी हैव ए प्रोटोकॉल. ये TNF इनहिबिटर चालू करने का पहले हम लोग एक मंटू टेस्ट, एक टीका जो होता है बाहर हाथ में देख लेते हैं, और चेस्ट एक्सरे, कोई किसी ना किसी एडवाइस करते हैं, कोई CT स्कैन, तो हम लोग दोनों तो करते ही है, 112 टेस्ट 1 चेस्ट एक्सरे, ये दोनों में पॉजिटिव आ गया तो हमारा वी स्टैम्प कि हमारा अंदर में टीबी का बीमार जर्म है वो सो रहा है। तो टीएनएफ देने का पहले हम लोग 4 महीना के लिए INH या रिफॉर्म पेशेंट, इसको कहते हैं प्रोफिलैक्टिक प्रिवेंशन, सो दैट बाद में टीबी ज्यादा ना हो जाए, आ नहीं जाए, जो हम लोग प्रिवेंशन के लिए INH रिफॉर्म पेशेंट देते हैं। उसके बाद हम लोग चालू करते हैं TNF इनहिबिटर, एंड दैट्स रियली मॉडिफाइज ये टोटल डिजीज का जो आउटकम टोटली चेंज हो गया। और रेगुलर, लेकिन प्रॉब्लम वही है, रेगुलर लेने पड़ता है, एवरी 2 महीना 3 महीना बाद लेने पड़ता है, 5 मिलीग्राम पर kg पर वायल पर डोज ऐसे लेने पड़ता है। तो वी नीड टू बैलेंस। तो हम लोग ऐसा ही करते हैं आजकल, क्या SOS जब जरूरत पड़े तो देना है, अदरवाइज इफ यू कैन मैनेज एक्सरसाइज करके पेन किलर लेके। सो वन शुड नॉट, आई रिपीट, it's not only pain relief होता है, ऐसा नहीं है, it's not a pain killer only, to start with it's pain killer, but for this यही disease के लिए ये disease का भी modify करता है, वो bone जो formation हो जाता है वो भी control होता है, and movement भी ज्यादा हो जाता है, and then the cytokine जो release होता है वो भी थोड़ा सा modify होता है। तो I think this is the main issue. So with regular exercise, regular NSAID, if required TNF inhibitor, ऐसा combination therapy and regular follow up, और आंख का इन्वॉल्वमेंट हो गया तो ऑप्थेल्मोलॉजिस्ट को साथ साथ rheumatologist और गुड क्लिनिशियन को साथ हम लोगों का we need to have combined protocol management issues, and once you have gotten ankylosing spondylitis and if you have good exercise and अच्छा करके दवाई लेते, तो आप भी दूसरा पेशेंट जिस लोगों को हो गया ना, तो उस लोगों को भी यू कैन स्टिमुलेट, नथिंग टू वरी, एंड इट्स नॉट दैट वंस यू हैव दिस वन यू हैव अ कॉम्प्रोमाइज लाइफ। लाइफ कुछ कॉम्प्रोमाइज नहीं होता है, लाइफ नॉर्मल लाइफ लीड करते हैं, बहुत सारे पेशेंट एकदम नॉर्मल लीड करते हैं, लेकिन उसको साथ साथ ये दोनों लेने पड़ता है। दैट इज द प्राइमरी इशू। आई थिंक ऐसा ही द टोटली नटसेल में डिजीज के बारे में ऐसा ही, इफ यू कीप दिस वन तो बस हम लोग आराम से जी सकेंगे विद दिस डिजीज एज वेल। थैंक यू।
Thank you, Professor. I can see my teacher logged in, Dr. Amita Agrawal, Professor Madam. So welcome, Madam. Nijil's and my teacher, she's also there. Thank you, ma'am, for joining. We now have Professor Nijil speaking, and so because I might have to translate a bit of that in Hindi, I'll try my best because Nijil is going to be a complicated kind of thing. But Nijil, you can go on, and then I'll try and simplify it into a bit of Hindi if I can, after you end.
Yeah. So what I will do, okay. So what I've done is I've made some very simple slides, so it is easier to follow. What maybe we could do is I can stop after 3 or 4 slides, and then maybe Sapanbhai, what you could do, you maybe translate it into Hindi so it becomes a little easier.
Okay.
And we'll go very slow, and we don't need to cover the entire thing. We can cover the rest of the stuff in during question and answer session.
Yeah.
Okay. So let me share the slide here with you. Good. Okay. So what people try to do is try to understand what causes AS. What is the underlying reason for ankylosing spondylitis? Obviously, science has progressed significantly. So many investigations are being done by so many smart people around the world that the science has gone really ahead, and we have progressed in our understanding of AS significantly. But the problem still remains. It is like a jigsaw puzzle. So we know pieces from here and there, but we don't know exactly how to put them together and make the final picture. So still we are in the dark regarding the final cause of ankylosing spondylitis, but at least we know a lot of the pieces that are important. Okay, so we'll try to look at those and then connect these causes to the currently available treatment. Okay, so when we look at cause of ankylosing spondylitis, or we look at cause of any disease, there are 2 main things that are important. Okay, one is our genetics, what we are born with. Okay, our genes are very important, and the other part is what we are exposed to, our environment. In case of ankylosing spondylitis, it looks like the genes are much more important than the environment. But as we discover more, maybe that little circle of environment can start increasing in size, and we may realize that, okay, environment is also very important. And the first evidence of genes in ankylosing spondylitis came from family studies. Okay, so if you have a family with more than one person affected by ankylosing spondylitis, then you can have a collection of these families and look at study them in greater detail. So these are twins. What is the Hindi for monozygotic twins? I don't know.
You just go ahead, I'll tell later, no problem.
Yeah, okay. So essentially, these are twins where there is greater gene sharing. And these are twins with less gene sharing. So there is more gene sharing in this family compared to this family. And you will see that 10 में से 5 लोगों को ankylosing spondylitis, they occur together. Out of 10 families, in 5 families, they occur together. And when there is less gene sharing, out of 10 families, only 2 families have 2 people affected, right? Similarly, if you look at the relationship in families, you can see they are twins here, okay? Judva, right? I think that's what we call Judva. And then the first degree relative would be father, mother, brother, sister. Second degree relative would be grandfather, grandmother, and all. And third degree will be, uncle, chacha, mama, and all of those things. And if you look at those relationships and see how many people get ankylosing spondylitis, you will see that if you have greater gene sharing, Judva Hetu, there is a higher chance that you will have a sharing of ankylosing spondylitis diagnosis. Similarly, the chance of ankylosing spondylitis, for example, for somebody who has ankylosing spondylitis, the chance of the child developing ankylosing spondylitis is around 10%. 10% chance for the next generation to develop ankylosing spondylitis. Maybe we can stop there, and maybe Sapamba, you can just translate a little bit so far.
You hardly spoken in प्रोफेसर निजिल ने जो अभी तक बातें कही हैं मेनली ये कि किसी भी जो हमारे ऑटोइम्यून डिजीज माने इस तरह की जो भी बीमारियां होती हैं जो इम्यून सिस्टम की रोग प्रतिकारक शक्ति की जो बॉडी को परेशान करती है, हमारी ही बॉडी को, उसमें अलग अलग तरह की बीमारियां होती हैं. उसमें एक जीन्स होता है माने जो ट्रांसमिशन जो हेरिडिटी आती है फैमिली में से वो, और एनवायरनमेंट माने ये वायरस, जैसे कोरोना वायरस भी एक तरह का वायरस है, ऐसे वायरसेस और एटमॉस्फेयर में कई सारे और भी तत्व होते हैं जिनकी वजह से वो, तो आप में कुछ तरह के जीन्स अगर जन्म से हैं, प्लस ये जो एटमॉस्फेयर में जो वायरस और बाकी सब सिगरेट स्मोकिंग, ये सब जो फैक्टर्स हैं, वो मिल के इस तरह की बीमारियां करते हैं. अगर दो में से एक चीज़ हो तो हो सकता है बीमारी ना भी हो, लेकिन दोनों चीज़ें ज़रूरी, तो जब भी फॉर्मूला बैठता है तब जाके बीमारियां होती हैं. और इस तरह की बीमारियां होती है, एक बार शुरू होती है तो वो फिर लगातार चलती रहती है लंबे समय तक, ज़्यादातर केस में ज़िंदगी भर. तो इस तरह से एंकिलोजिंग स्पॉन्डिलाइटिस भी इसी तरह से होता है. और जो डॉक्टर साहब ने समझाया है ये जीन्स के बारे में, मोनोजाइगोट माने वो एक ही पिंड में से जो बनते हैं, दो जो ट्विंस निकलते हैं, वर्सेस दो अगर पिंड हो उसमें से बनते हैं, वो डाइजाइगोटिक बोलते हैं. बेसिकली मोनोजाइगोटिक में जीन्स ज्यादा शेयर होते हैं, मतलब वो सेम जीन आते हैं. अगर जीन्स की जितनी ज्यादा इन्फ्लुएंस हो उन जुड़वा, उसमें ज्यादा एंकिलोजिंग स्पॉन्डिलाइटिस देखा गया है, जैसे उन्होंने बताया है. तो मैंने हेरिडिटी का बहुत इंपॉर्टेंट पार्ट है इसमें डेफिनेटली. अगर आपको एंकिलोजिंग स्पॉन्डिलाइटिस है, और आई एम श्योर कि वो क्वेश्चन बाद में आएगा कि मेरे बच्चे को कितना चांस है, तो प्रोफेसर साहब का कहना है कि 10% चांस है कि आपके बच्चे को भी एंकिलोजिंग स्पॉन्डिलाइटिस हो सकता है. अभी तक इतनी बात हुई है.
Well, the good news is that 90% chance that the next generation will not get ankylosing spondylitis. So there is no need to be really anxious about it. Okay. So the most important gene, as we all know, and Professor 𝐊𝐞𝐲 also alluded to it and talked about it, is HLA-B27. So HLA-B27 is still the strongest gene that is associated with ankylosing spondylitis. So in this cartoon, I'm trying to explain what HLA-B27 does in AS, and just if you can understand well and good. Otherwise, it's not a big issue. So when we have an infection, for example, COVID-19 is one virus that we are exposed to these days, and everybody is reading about it. When we have a virus like that, we have a cell called antigen-presenting cell. The virus is taken up by our cell and is presented to our army of protective immune system. And that happens by presenting only a small part of the virus. And that small part of the virus is presented on a plate to our immune system, right? And so now our army of immune cells can come in and actually kill the virus and also the cells that contain the virus. So that is how we get rid of a viral infection, okay? So for example, COVID is coming in, our immune system will present it to this sword-wielding T cell, which is part of our immune system, and this immune system will get rid of the virus. Now let's go back to that picture again. Now this hand that actually presents the virus to our immune system is HLA-B27. HLA-B27 is just an example of this hand. So HLA-B27 is a normal gene. It is normally present in our body. The vast majority of individuals who have HLA-B27 have no disease. And the normal function of HLA-B27 is to present a virus. Now, just to give you a sort of an impact of having HLA-B27, a positive impact. Those who are HLA-B27 positive have less chance of hepatitis C virus infection, okay? That is another virus, hepatitis C, that causes hepatitis. And if you have HLA-B27, our body can present hepatitis C to our immune system and we have better control over hepatitis C. Similarly, HIV. If somebody gets HIV, the virus is presented by HLA-B27 and the chance of it progressing to AIDS is much lower. So really it is in some circumstances, HLA-B27 is a good thing to have, okay? So that the problem in AS is when this interaction between B27 and the rest of the immune system starts to lead to a lot of inflammation, okay? So here is an example. This is just to show you the effect of HLA-B27. This is from an animal experiment. This is a mouse. This is a rat. And you can see that just by adding HLA-B27, the rats develop arthritis. They develop nail changes of psoriasis. They develop skin changes of psoriasis. And they develop IBD. I saw some questions on colitis in the chat. Colitis also develops just by introducing HLA-B27 into this rat model. That shows that HLA-B27 is important in these diseases. However, as 𝐊𝐞𝐲 sir was mentioning, if you look at all AS patients, out of 100 people with ankylosing spondylitis, 90%, around 85 to 90% will have HLA-B27. So it looks like it is really important. However, in India, if you test everybody for HLA-B27, I think around 5%, I believe 5 to 6% would be the prevalence of HLA-B27 there. In Canada, it will be 7%. So a lot of people have HLA-B27. But out of 100 people with HLA-B27, only 2 develop ankylosing spondylitis, right? So 98% of people who have HLA-B27 do not have the disease. Now this is important, especially we see a lot of patients in clinic who have back pain and they come with an HLA-B27 positive test and are referred for starting biologics and because the pain is not improving. But the fact is they don't have ankylosing spondylitis. Chronic back pain, if you screen everybody in India for chronic back pain, I would say 25 to 40% of people will have chronic back pain. But actual ankylosing spondylitis may be less than 1%, right? So the vast majority of back pain is not ankylosing spondylitis, and the chance of a B27 positive individual having ankylosing spondylitis is only 2%. Now B27 plus back pain and the kind of back pain, the chance keeps on increasing. So just by having B27, don't think you have ankylosing spondylitis, okay? Now that brings us to, I'm not going to go into all of these genes, but by now we have over 140 different parts of our gene that have been linked to ankylosing spondylitis. So we started with one gene, HLA-B27, and now we have 140 or more different parts of genes that are linked to AS. And as I mentioned before, how do they all link to each other and cause AS is not known. I'll give you one example of, and this is the importance of studying families. This is one family that we studied here in Newfoundland. Okay, Newfoundland is on the east coast of Canada, and we have this family that has a lot of intermarriages. You can see. So this is the father and mother, grandfather, grandmother, and then they have kids. How many kids? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12 kids. Okay, so they have 12 kids, and they have married. There is a lot of intermarriage happening in this family. Okay, so ultimately in this family, there were 9 people who had a new mutation that has not been described before in AS. This particular gene, and they also had HLA-B27. And as I mentioned before, the chance of AS patients, the chance of ankylosing spondylitis in an HLA-B27, in 100 people HLA-B27 is only 2, right? Only 2% of people get AS. But here, out of 9 people with HLA-B27 and this mutation, all of them, 100% developed ankylosing spondylitis. So that shows that this combination of one gene and the other led to a very high risk of ankylosing spondylitis. So if we get clues like this, so if you are aware of families with multiple people involved, you should probably approach Sapan sir, Amita madam, or 𝐊𝐿𝐞𝐲 sir and try and get this investigated, because the next discovery in ankylosing spondylitis might come from such studies. And this was a novel discovery that we made. And in one slide, I will tell you, just to for interest's sake, this work was done by my postdoctoral fellow Mike. So we talked about HLA-B27 and HLA-B27 going to the surface to present the virus. So that actual journey to the surface is mediated by this new gene. So now you see how in the same function is being mediated by 2 different genes, leading to, you see that process of going to the T cell, that is mediated by this new gene. So when both B27 and this new gene is affected, you get the higher chance of getting ankylosing spondylitis. And I believe this is the final slide on the immune system and inflammation. This is just to connect what we know about the immune system and the treatments that we have. Okay, so we have we have HLA-B27 inside a cell. The cell gets very active. A lot of inflammation is triggered. The primary cytokine, or the molecule that is produced by our immune system from here, is interleukin-23. It triggers further cells to produce interleukin-17, and that further triggers cells to produce TNF-alpha. And we know that we have at least 5 TNF monoclonal antibodies to treat AS. We also now have 2 IL-17 inhibitors to treat AS. For some reason, interleukin-23 inhibition does not work in ankylosing spondylitis. IL-23 inhibition is excellent for psoriatic arthritis, but not for ankylosing spondylitis. So for some reason. If you look at newborn formation is the next major part of ankylosing spondylitis. So there is inflammation we talked about, and now we'll talk about newborn formation. So this is one example of a person. You can see this is the X-ray at baseline. This is the lower back X-ray. If you see, there is no fusion happening here, but there is some white area here. And if you see here, there is one spot that is already fused. Okay. And this is 4 years later. You can see that it's completely fused. Similarly, here is the neck. And you can see a little area here which is fused, but the rest of the stuff is not fused. And here you have complete fusion happening over a period of 4 years. And also the posterior part of the neck is also fusing, and that limits the movement of the neck. Now, this is an extreme example. It is very rare to have such rapid progression of disease. Most people don't have that rapid progression of disease. And we have around 1,500 patients in our database. And if you look at these patients over a period of 4 या 6 साल follow-up में देखेंगे, तो around 60%, 60% लोगों को कोई, there is no progression at all happening. And in around 10 to 20% बहुत ही fast progression होता है. So the interesting thing is to find out what causes this fast progression. What are the reasons behind the fast progression? And we know that a lot of inflammation drives bone formation. So that is why it is important to treat very early and block the inflammation. Here is an example from an MRI. If you see, that is the MRI of the spine, okay? And in one corner here, you can see a white spot. You can see a white spot here, a white spot here. That indicates inflammation. So if you look at two areas, here you have white spots where there is a lot of inflammation, and here it is dark, there is no inflammation. And now you try to follow them with X-ray over after 2 years, okay? You'll see that there is bone formation happening where there is inflammation, no bone formation happening where there is no inflammation. So if you treat well, the idea is you can control this inflammation and not let this bone formation to happen. So जितने जल्दी हो सके, if we can start treatment, inflammation को कम कर सकते हैं, और ऐसे bone fusion और spinal fusion को और deformity को हम prevent कर सकते हैं. Now, we also know that in these spots, if you do a biopsy in the sacroiliac SI joint or sacroiliac joint in the low back, you know that there is a lot of TNF and IL-17. You can see it. Similarly, in the spine also, there is TNF and IL-17. Okay. And the other part, important part that we know is smoking. So 𝐊𝐞𝐲 sir already mentioned that stopping smoking is so important. You will see here, this is 10 pack years, which means every day, har roj, if you smoke cigarettes and you have more than 10 pack years, okay, so if you have more than 10 pack years, then this will be the rate of progression बहुत ज़्यादा है compared to somebody who doesn't smoke. Okay, so if it is very difficult to stop smoking, at least start by decreasing the number of cigarettes, and then hopefully later on stop smoking. And there are 3 reasons, at least 3 reasons that we know of why smoking should be stopped. One, we already mentioned, it increases the rate of spinal fusion. Second one is there is a 35%, 35% ज़्यादा chance है heart attack and stroke की वजह से मौत होने का. I mean, the mortality is very high with heart attack and stroke related mortality is high in ankylosing spondylitis over many years, not immediately, over many years. So smoking will add to that risk. Finally, if you're taking treatment, for example, if you're taking biologic treatment, the chance of success of the biologic treatment is lower if you smoke. So many reasons why you should stop smoking. Okay, sir, maybe Satyam, maybe if you could just briefly give a little bit, yeah.
पिछली जो लास्ट 5-6 साइज में डॉक्टर साहब ने काफ़ी अच्छी बातें की हैं, ये मैकेनिज्म समझाया किस तरह एंकलोजिंग होता है. उन्होंने एक बहुत अच्छा डायग्राम बनाया जिसमें उन्होंने बताया है कि HLA-B27 है क्या चीज़. HLA-B27 जो हमारे अंदर बॉडी में ब्लड में जो सेल्स होते हैं, जो कोश होते हैं, और वायरस जैसे इन्फेक्ट करता है, ऊपर उन्होंने बताया कि वो वायरस जैसे वायरस सेल के अंदर आता है, तो HLA-B27 ये जो हाथ उन्होंने दिखाया है वो चीज़ है जो हाथ HLA वायरस को, और जो तलवार वाला दिखाया वो बॉडी की इम्यून सिस्टम का सेल है, वो हमारी आर्मी है. मुझे लगता है ये फोटोग्राफ तो हम निजल साहब से ले ही लेंगे हमारे. इट इज सच अ गुड डायग्राम. सो इसमें दिखाया है कि वायरस जो हमारी बॉडी में घुसता है और सेल के अंदर जाता है, जैसे कोरोना है या HIV है, उन्होंने बात की, हेपेटाइटिस C वगैरह. तो ये जो HLA-B27 वो एक हाथ है सेल का, कोश का, जो वायरस को प्रेजेंट करता है हमारी आर्मी को, ताकि हमारी आर्मी उसे मार दे. उन्होंने बहुत खूबसूरत तरीके से बताया है. HLA-B27 से ये काम करता है, तो इट इज़ अ वेरी यूजफुल थिंग फॉर द बॉडी. HLA-B27 उन्होंने बाद में ये भी बात बताई कि अगर आप, जो हम बताते हैं सारे पेशेंट्स को, अगर आप 100 एंकलोजिंग स्पॉन्डिलाइटिस का HLA-B27 करवाए तो उसमें 90% पॉजिटिव आएगा. लेकिन अगर आप HLA-B27 सिर्फ देखें तो उसमें से केवल 2 या 5% को एंकलोजिंग स्पॉन्डिलाइटिस होता है. 2% उन्होंने कहा है, बाकी सबको एंकलोजिंग स्पॉन्डिलाइटिस होता ही नहीं है. तो हमारे पास कई बार क्वेश्चन आता है कि सर हमारा HLA-B27 पॉजिटिव है, तो दैट इज नॉट अ प्रॉब्लम. मतलब फिर आपका चांस बहुत कम है. अगर आपको कोई और इश्यू नहीं है तो। लेकिन हाँ, अगर आपको एंकलोजिंग है तो B27 पॉजिटिव हो सकता है। तो HLA-B27 एक बॉडी की, एक सेल की बहुत काम की चीज़ है जो वायरस को निकालने में काम कर रही है। पहली चीज़ वो थी। दूसरा उन्होंने बताया, उन्होंने ये कोश बताए हैं जो हमारे इम्यून सिस्टम के अलग अलग सेल्स हैं, वो जो ये IL-23 और IL-17 बना, ये बेसिकली साइटोकाइंस बने, वो बॉडी का एक नॉर्मल रिस्पॉन्स है जो निकलता है लिक्विड बाहर, लिक्विड टाइप का निकलता है, जिससे हमारी बॉडी की इम्यून सिस्टम फंक्शन करती है। और जब वो बहुत ज़्यादा बनने लगता है तो इस तरह की बीमारियां होती हैं। तो साइंटिस्ट इन्हीं जो साइटोकाइंस, ये जो आपको मॉलिक्यूल्स दिख रहे हैं, उनको टारगेट करते हैं ट्रीटमेंट के लिए। जैसे IL-17 का ट्रीटमेंट सेक्युकिनुमैब है हमारे पास, स्केफो। IL-23 का ट्रीटमेंट भी अवेलेबल है जो एंकिलोजिंग में काम नहीं कर रहा है लेकिन सोराइसिस में काम करता है। तो इस तरह से कई सारी हमारे पास, और TNF अल्फा के अगेंस्ट भी हमारे पास वो उनके मॉलिक्यूल्स भी हैं। फिर उन्होंने बात की है बोन फॉर्मेशन की, कि जो उन्होंने दिखाया है बहुत अच्छे खूबसूरत एक्सरेज में, कि जो 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 लोग फ्यूज हो गए हैं, कई लोगों ने क्वेश्चन भी पूछे हैं कि फ्यूजन मतलब क्या, मतलब जो बिल्कुल जुड़ जाते हैं, मुड़ जाते हैं, ऐसे देख नहीं पाते, बाई तरफ दाई तरफ उनके एक्सरे में सारा फ्यूज हो गया होता है गले में और नीचे स्पाइन में, जिसको बैम्बू स्पाइन बोलते हैं। वो बहुत सालों पहले इन्फ्लेमेशन से शुरू होता है, मैंने 10-15 साल पहले सूजन शुरू हुई थी और इस तरह का एक्सरे में व्हाइट और MRI में व्हाइट एरिया से, और बाद में वो बोन बन गया, हड्डी बन गया। तो अगर आप अर्ली स्टेज में हैं, इन सारी हमारी बीमारियां बेसिकली 2020 मैच की तरह है। आपको पहले 5 ओवर में 50, 60, 70 रन बना देने हैं, तभी वो बीमारी को आगे रोका जा सकता है। तो अगर आप पहले उसको कंट्रोल कर दें तो इस तरह का फ्यूजन होने का चांस कम रहता है। हालांकि फ्यूजन होता है सिर्फ, उन्होंने बताया 10-20% में, बहुत फास्ट प्रोग्रेशन जनरली नहीं होता है। उन्होंने अपनी स्टडी में बताया कि 50-60% को तो 5-6 साल में ज़्यादा बीमारी प्रोग्रेस ही नहीं हुई थी। तो ज़्यादातर केस में बहुत इश्यूज नहीं होता है, सिर्फ 10-20% में होता है। दूसरी, डॉक्टर साहब ने बात की उनके एक रिसर्च की, जिसमें उन्होंने एक नया जीन ढूंढा है जिसमें पूरी फैमिली में ट्रांसमिट हुआ था। खैर उसके बारे में वो ज़्यादा साइंटिस्ट के लिए इम्पोर्टेंट है। और लास्ट में स्मोकिंग के लिए, कि स्मोकिंग से एंकिलोजिंग स्पॉन्डिलाइटिस की प्रॉब्लम्स किस तरह बढ़ती हैं। एक तो जो फ्यूजन की बात की वो बढ़ जाता है उससे। दूसरा कि वैसे भी स्मोकिंग वालों को हार्ट अटैक का रिस्क रहता है, एंकिलोजिंग स्पॉन्डिलाइटिस वालों को भी हार्ट अटैक का रिस्क रहता है। तो दोनों को अगर मिला दो तो करीब 35% बढ़ जाता है। इसलिए स्मोकिंग जो हमारे हाथ में, एटलीस्ट वो तो बंद कर दें। और लास्ट, आप जो ट्रीटमेंट ले रहे हो उसकी इफेक्ट कम हो जाएगी अगर आप स्मोक कर रहे हो। जैसे बायोलॉजिक ट्रीटमेंट ले रहे हो, अगर आप स्मोक कर रहे हो तो उसकी इफेक्ट कम हो जाएगी। जहाँ इतनी महंगी ट्रीटमेंट ले रहे हो, तो मेरे हिसाब से और डॉक्टर साहब के हिसाब से स्मोकिंग जो हमारे हाथ में है उसको बंद करना ट्राई करना चाहिए। अगर बंद नहीं हो पाता तो एटलीस्ट बिल्कुल कम कर दें, लेकिन मेरे हिसाब से बंद ही कर देना ठीक रहेगा इसमें। सो इतनी बातें उन्होंने बताई हैं। अब आगे ट्रीटमेंट की बात करेंगे डॉक्टर साहब। थैंक यू।
Okay, so that's excellent summary. Thank you. There is a window of opportunity is a concept in treatment of a lot of diseases. Now, जितनी जल्दी ट्रीटमेंट शुरू कर सकते हैं, the outcome इतना ही better होगा, तो जो रिजल्ट है उतना ही बेटर होगा। तो कैंसर में हम देखते हैं कि जितने जल्दी हो सके उसका डायग्नोसिस कर ले और दवाइयाँ शुरू कर ले, तो कैंसर में सर्वाइवल की चांस बहुत ज़्यादा रहते हैं। रूमेटॉइड में भी ऐसा ही, हमने बहुत साल पहले से ही हमने ये ऑब्जर्व किया था कि अगर रूमेटॉइड आर्थराइटिस 3 या 6 महीने के अंदर ही ट्रीटमेंट शुरू करेंगे, तो compared to somebody who starts treatment like 4 or 5 years later, बहुत ही डिफरेंस है आउटकम में। ये जो जोड़ों की डिफॉर्मिटीज वगैरह प्रिवेंट करने में बहुत ही डिफरेंस रहता है if you diagnose these patients early and start treatment. Now, for ankylosing spondylitis also, time is very important. Now, one of the reasons is early diagnosis means early treatment start. And if you start treatment early, अगर हम जितना जल्दी हो सके ट्रीटमेंट शुरू करते हैं, तो at least we know of 3 major things that can happen. 3 major things. One is those who start treatment early, higher chance of response. पेन कम करने में और इन्फ्लेमेशन कम करने में चांसेस बहुत ही हायर है if you start treatment much earlier. Second one is higher chance of drug free remission. मान लो आपने बायोलॉजिक शुरू कर लिया, कोई भी बायोलॉजिक शुरू कर लिया, let's say for example रेमिकेट शुरू कर लिया, you take it for a year. 1 साल लेने के बाद अगर बंद करने की कोशिश करेंगे तो हो सकता है कि आपको फ्लेयर अप हो। लेकिन आप बहुत ही अर्ली ये दवाई शुरू करते हैं तो स्टॉप करने का चांसेस ज़्यादा है। देयर इज अ हायर चांस ऑफ ड्रग फ्री रेमिशन if you start treatment early. The third thing is you saw the spinal fusion happening. ये जो हड्डियाँ जुड़ जाने का ये जो प्रॉब्लम है, डिफॉर्मिटी होने का प्रॉब्लम है, वो you can reduce the chance of progression if you start within, let's say, 1 year or 2 years compared to after 10 years. Okay, so at least 3 main reasons why you should start the drug early. This is just one example, and I will just explain this graph so you can follow. This means a 40% improvement. हमारे जो अगर पेन 10 है तो उस वहाँ से 10 में से 6 और पेन लेवल कम करने का चांस. So 40% decrease in symptoms at 24 weeks. 6 महीने के ट्रीटमेंट के बाद 40% improvement होने का चांस कितना है? Let's see. And these are the different drugs you know of. This is infliximab, etanercept, adalimumab, golimumab. I don't think all of these are available in India, but at least the first 3 are probably available. Sapamba, is golimumab available in India now?
Yes.
Okay, so all are available. How about certolizumab?
No, certolizumab is not available.
Okay, so at least all these are available in India now, and you'll see the chance of response of only 40% response in treatment is less than 50%. Okay, so it is not like a magic drug. It is a very good drug, but the chance of response is only less than 50%. And the reason why I believe it is so in this is because the people who were entered, the AS patients who entered the study, who were given the drug, all had an average of around 15 years of disease. So more than 10 years of disease. And it's very difficult to treat when the duration of treatment increases. Now let's compare these numbers to another study here. This is another study here. And here, the duration of symptoms was less than 3 years. So quite early on, the patients were included. And if you look at a chance of 40% response, more than 60%. And the chance of remission, which means almost no symptom, more than 50% of patients had almost no symptoms with treatment. And the main difference is that people started the treatment very early. So this just shows you the chance of response is very high. Now, this is just an algorithm. We will be winding up very soon now. Patients generally, all patients should be doing exercises. Doing exercise as a group in group settings is much better than doing exercises at home. If you can swim, it is really good. But if you look at the American College of Rheumatology recommendation, they have recommended land-based exercises, because if we tell patients to do pool-based exercises and pool is not available, they will not exercise at all, right? So some form of exercise for the back is very essential. If you can do pool-based exercises, well and good. If not, that is fine. Okay, then we have TNF inhibitors, and then we have interleukin-17 inhibitors. If the anti-inflammatories don't work, for example, you have naproxen, celecoxib, indomethacin, all of these are drugs. The minimum period for which we should try these drugs is one drug should be tried for at least 2 to 3 weeks. For example, you start naproxen, don't think that the next day you will get improvement. Every day you should take it on full dose for approximately 2 weeks to say whether it is working or not. Now, if you try 2 of these and it doesn't work, go to Biologics, and you know there are TNF inhibitors and IL-17 inhibitors. 5 different TNF inhibitors that are available for us, of which 4 are available in India. Secukinumab is available in India for IL-17. I don't know. Sapamba, is ixekizumab available?
No.
Not yet. Okay. So ixekizumab is available now here. It's approved, FDA approved. Soon it should be available in India. So we have 2 different options for IL-17 inhibition. In terms of future treatment, I think in the if you look at the American College of Rheumatology recommendation, this was from 2018. I don't think we need to go into a lot of this, but I'll just mention that isolated sacroiliitis. So if there is inflammation only in the sacroiliac joint, you can try and inject steroid into the sacroiliac joint. The other thing which I wanted to mention is there is a lot of eye inflammation or inflammatory bowel disease. The choice of the drug that you take may be important. And those are things which you can discuss with your treating doctor. And finally, you'll see here, tofacitinib or a JAK inhibitors, and there we have also another JAK inhibitor, upadacitinib, that is soon hopefully going to be available for treatment of ankylosing spondylitis. The biggest advantage I find of these is that it is an oral medication. You don't have to inject. So being an oral medication, it is much easier for patients to take. There are other potential treatments in the future, and if we have time, we can discuss those as well. Finally, can we slow progression? I don't want to take too much of time on this. What I will just show you is that this refers to the rate of progression in patients who started treatment within 5 years. So patients started TNF inhibitor. It could be any TNF inhibitor. It could be infliximab, etanercept, golimumab, or certolizumab, or it could also be adalimumab. Any of these. If you start within 5 years, this is the chance, this is the rate of progression. And if you start after 10 years, this is the rate of progression. That clearly shows if you start early, you can slow the progression, higher chance than compared to start late. And this is just an example. The blue dots, each of those dots are patients. Blue में जो दिखाया है, ये 10 साल के बाद, बीमारी के 10 साल के बाद दवाई शुरू किया है, और ये जो लाल रंग में दिखाया है, ये 10 साल के अंदर दवाई शुरू किया. And you can easily see almost 60% of people who started the drug after 10 years have progressed. And only 20% of those who started less than 10 years have progressed. So clearly that is a big difference between starting early versus starting early versus starting late. So higher chance of preventing progression if you start the treatment early. The IL-17 inhibitor like secukinumab, there is no strong data yet of slowing progression because it is just we started using it only 4-5 years ago. Data is coming, and soon we will have the same kind of data for IL-17 inhibitor as well. And here is one example, and this is just an animal experiment. At least this is sort of giving us the idea what can happen. You can see here in a lot of newborn formation happening on the surface, and when IL-17 inhibitor is given, all that newborn formation is going away. Right? So there is a chance that IL-17 inhibitors can prevent progression. So just to summarize, we talked about all the different molecules involved in inflammation. We talked about how IL-17 and TNF are important mediators of inflammation. We talked about progression, spinal fusion, bamboo spine formation. We talked about the modalities of treatment, how you treat with exercise, anti-inflammatories, and biologics. We talked about the importance of treating early and how that can prevent progression, how that can improve response, how that can even improve the chance of us stopping drug later on. And finally, we talked about the ability of these drugs to stop progression. I think I'll stop there.
थैंक्स निजिल. सो 3 बातें उभर के आई लास्ट स्लाइड्स में, काफी सारी बातें की, लेकिन 3 जो मेन बातें थी, एक तो डॉक्टर साहब ने कहा है कि लैंड एक्सरसाइजेज, आप वहाँ पे पूल बने, स्विमिंग पूल और वाटर में एक्सरसाइजेज भी रिकमेंड करते हैं, लेकिन हमारे यहाँ सबके यहाँ सुविधा नहीं होती, तो आप एटलीस्ट लैंड में एक्सरसाइजेज या आपके डॉक्टर जो चार्ट्स दें और फिजियोथेरेपिस्ट जो बताएं वो एक्सरसाइजेज करें. एक्सरसाइज बहुत ज़रूरी है इनके लिए. दूसरी चीज़ बार बार उभर के आती है कि इन सब बीमारियों में जब लोहा गर्म होता है तभी मारना पड़ता है उसको, तो मतलब जितना स्टार्टिंग में आप जल्दी उसको ट्रीट करें, चाहे आप nsaids लें, चाहे TNF इनहिबिटर्स लें, चाहे IL-17, जो भी आपके रूमेटोलॉजिस्ट डॉक्टर साहब हैं वो ट्रीटमेंट शुरू करें, उसको अगर लगातार लेते रहें तो बाद में उसका प्रोग्रेशन बढ़ने का चांस बहुत कम रहता है. तो शुरुआत से ही उसको जितना हो सके जल्दी डायग्नोसिस करके ट्रीटमेंट शुरू करना है. और तीसरी चीज़, कुछ ओरल मॉलिक्यूल्स टोफैसिटिनिब और हमारे यहाँ भी अवेलेबल हैं, ये बायोलॉजिक्स के बाद जो नई ट्रीटमेंट सबसे आई हैं वो भी अवेलेबल हैं, तो वो आजकल इसमें यूज़ हो रही है और उसका भविष्य भी अच्छा है. डॉक्टर साहब कह रहे हैं हमारे यहाँ भी कुछ मॉलिक्यूल्स आएंगे, हालांकि ये बहुत महंगी दवाइयाँ हैं, लेकिन द फ्यूचर इज सीम्स टू बी प्रॉमिसिंग. तो ये 3 बातें उभर के आई. थैंक्स निजिल अ लॉट. सो नाउ आई थिंक अमी विल गो विद द क्वेश्चन आंसर फॉर एटलीस्ट another 15 minutes and then you can take over from there. We have about 15 to 20 minutes of time. काफ़ी सारे Yes, you're saying something?
Sure, sir, you can take the questions now.
So there are quite a few questions. बहुत सारे questions आए हैं. लेकिन I'll go through some of the main ones, and I would want Professor 𝐊𝐞𝐲 to first take up some of the questions on most of the questions as usual are on the treatment part, which is most relevant to the patients. So the first thing is about NSAIDs के काफी लोग questions है कि कौन सी NSAID सबसे अच्छी है. Number 2, कब तक NSAID तो पेन किलर है तो वो कब तक लेना है? You said that in your talk, but they want a re-emphasis. And another question, the third one NSAID was one for one person who has a renal problem. So can he take paracetamol, or if they cannot afford biologics, and what are the treatment options for these kind of patients?
Right. Thank you. NSAID के बारे में हम लोग जो बताया है तो theoretically, scientifically, evidence based, all NSAIDs are equal, whichever is comfortable. But practice wise, हम लोगों ने तो etoricoxib इधर तो चालू है, तो we starts with etoricoxib 60 milligram or 90 milligram. How long to take? That's then another issue. So far the reference literature are concerned, 6 महीना से 2 years, from 6 months to 2 years you can take. But the concern is, one is liver enzyme problem and another part is creatinine. So person who has got a raised creatinine certainly cannot go for NSAID. Only etodolac has been documented to have relatively renal safety profile, but otherwise one has to balance with the paracetamol. That's the concern. But regular monitoring of routine blood, if hemoglobin comes down or in the setting of low hemoglobin, one cannot initiate NSAID. And liver enzyme, SGOT, SGPT, along with the creatinine regular monitoring. But a person who is not a smoker, not taking alcohol regularly, aspirin का कुछ बात है नहीं, तो जो issues conflicting होता है NSAID को साथ साथ, if one is not with those medication, so one can regularly take this one. But certainly with maintenance, follow up with your local physician, he is the best person who can guide you how long to take. Because once you start NSAID, इसके साथ साथ you have got a significant pain relief. But there is a comparative literature trial which has shown SOS NSAID versus जब दर्द होगा तब लेते हैं और रेगुलर NSAID दर्द कम हो गया उसके बाद भी रेगुलर NSAID लेते हैं एटलीस्ट once or twice in a week. तो रेगुलर NSAID का advantage it has been shown in literature. So it's better to continue, but with regular monitoring, with regular physician visits.
Okay, Nijil, you want to comment because it was your trial and the Andradas one on continuous versus intermittent, then I'll translate in simple language for them. And one person also asked if I'm asymptomatic or मुझे कोई problem नहीं है, then should I still take NSAID or not?
Yes, it is an important question. So historically, there has been a thought that anti-inflammatories can prevent progression. Okay, and if you look back to even days of phenylbutazone that we used to use many years ago, nowadays we use it only in horses because it is so toxic. People have looked at how it can prevent progression. And one of the early studies showed that maybe there is a hope of preventing progression if you take it regularly, full dose for continuously. But nowadays we know that after that Andrada study, we know that taking full dose versus taking it as and when required really doesn't make much of a difference. Now, some people still believe that it has some effect, but at least the current understanding and worldwide, the recommendation is that you take NSAIDs only if you need to, only if you have pain. For example, if your disease is well controlled on a TNF inhibitor, you don't need to take NSAIDs.
So, जो जहाँ तक पेन किलर की बात है, दोनों डॉक्टर साहब ने ये कहा है कि ये सिंपल पेन किलर नहीं है, ये आपकी बीमारी की भी दवाई है, बीमारी को भी कंट्रोल करती है, नंबर 1, और सब पेशेंट्स को कंटिन्यूस लेने की जरूरत नहीं पड़ती है. डॉक्टर निजिल साहब का ये स्टडी था जिसमें कहा है कि जिन मरीजों को एक्टिविटी रहती है वो आपके डॉक्टर जजमेंट लेंगे और आपकी मदद से कि एक्टिव है कि नहीं, तो उस हिसाब से आपको फॉलोअप करना पड़ेगा. तो वो सेकंड थिंग आई है. और तीसरी चीज़ के जिनको किडनी के इश्यूज है, प्रोफेसर 𝐊𝐞𝐲 साहब का कहना है उनको तो लेना मुश्किल है, तो उनको पैरासीटामोल या और कोई दवाइयों से ही ट्राई करना पड़ेगा. वो भी आपके जो ट्रीटिंग डॉक्टर है वो आपको मदद करेंगे उसमें. सो दिस वाज रिगार्डिंग NSAIDs. There are a lot of questions on biology, but I'll first go to the simpler things like posture. बहुत सारे questions. Nijil, if you can take that up, that posture, what is the best sleeping posture, how to improve on the posture. There are questions on the fusion of the neck, that they have a problem driving and all of those. So anything for that they can do, can you prevent that kind of complication by treating early? Those are questions which are there.
Yeah, so the basic, there are many reasons why you should exercise, starting from, cardiovascular fitness to, spinal mobility. There are many reasons. One of the important things that we talk about, in exercises and posture maintenance is that even if there is fusion, okay, let's say that nothing works, and even if there is fusion, if you maintain your posture well, when there is pain, there is always a tendency to slouch forward and decrease the pain. But if you try and maintain your posture as much as possible by exercises and also consciously when you're sitting, then your spine is very straight. Even if there is fusion, it will fuse in a functional posture. You know, the problem with spinal fusion is when you're not able to see forward, right? And you lose your horizon. That's the biggest problem with a fusion happening. But if you are maintaining your posture, even if you fuse, at least you can see everything in front. You can move what your waist and see on the side. Yes, driving is a problem because moving the neck may be difficult, but you can overcome that by using wider mirrors and also moving your body as a whole. There are ways to overcome those things. So the real importance of posture is even if there is fusion, you fuse in a functional way. One very practical thing that we tell patients nowadays, everybody's on the computer, right? And if you go to somebody who doesn't know about ankylosing spondylitis and ask them to adjust the desk, what they will do is they will adjust the lower level of the monitor at eyesight. Okay, so sorry, the upper level of the monitor at eyesight, and so you're looking down into the monitor. For ankylosing spondylitis patients, the eye level should be at the lower level of the monitor so that you're looking up, or slightly up, instead of looking down. So that's very, very simple things like that can, if you're working, for example, all day on a computer and you have that slight advantage of looking slightly up, you can see your spine is much straighter. So small things like that should be taken care of.
हाँ, तो डॉक्टर साहब ने बताया है कि जो नेक फ्यूजन पे कई सारी वो थी, तो आप चाहे कितना भी आपका लिमिटेशन हो, उतने लिमिटेशन भी अगर आप सीधे रहने की कोशिश करते हैं, तो एटलीस्ट वो थोड़ा सा बढ़ता हुआ रुक जाएगा, डॉक्टर साहब ने ये कहा है। और बाकी तो उसके लिए कंप्यूटर जो आप अगर आप कंप्यूटर में जॉब कर रहे हैं तो उसकी लेवल आपको इस तरह से एडजस्ट करनी पड़ेंगी, एंड देन यू हैव टू मूव योर बॉडी, बट यू कैन हैव दोस काइंड ऑफ एडजस्टमेंट्स। फॉरेन कंट्रीज में तो स्पेशल कार्स और स्पेशल मिरर्स भी होते हैं, अब हमारे भी शुरू हो गए हैं, और यही काम सब जो है जो एडवोकेसी ग्रुप या सपोर्ट ग्रुप कर सकता है मिलके, वी कैन आस्क फॉर दोस थिंग्स फ्रॉम द मैन्युफैक्चरर्स, हम तो गवर्नमेंट यही काम हमें करना है मिलके, तो लेकिन उसमें भी कई सारे उपाय है। Professor Alkindu, there are a lot of questions on diet. People are asking about diet and ankylosing spondylitis. There's any relation and what they should eat and what they should not eat. Would you like to comment on that part?
Really, there is no conflicting issues or no issues for diet recommendation. But once you take care that not to gain weight, so that's the most important concern. And so balanced proportionate diet which is required with a regular exercise and adequate normal protein, normal carbohydrate, and just proportionate less of fat. So the most important part is to restrict weight gain. So that's the most important part through the diet, which is important. Otherwise, you can have your normal diet regularly with a regular exercise, as we have discussed.
Thank you. तो प्रोफेसर साहब ने ये कहा है कि डाइट का विशेष कोई रिलेशन नहीं है जो हम लोगों को लागू पड़ता है, मतलब उम्र के हिसाब से कैलोरी थोड़ी कट करनी है, आपको ज़्यादा फाइबर डाइट लेना है, वही सब नॉर्मल चीज़ें जो होती है, ज़्यादा कैलोरी वाला डाइट मतलब, क्योंकि ऑलरेडी आपको बॉडी में एथेरोस्क्लेरोसिस का कॉम्प्लिकेशन होने का चांस ज़्यादा है, तो ऑयली फूड वगैरह कम लो, जो नेचुरल जो हमारे लिए वही आपके लिए है, कोई विशेष डाइट का रिलेशन प्रूवन नहीं है अभी। Nigel, there are lots of questions on biologics, so we'll move to some of those. The most common being, of course, tuberculosis is a problem in our country, and some of them who are also somebody is a resident in a medical college and she's got tuberculosis now, or he's got tuberculosis now, has ankylosing spondylitis. So in the future, then, if they were to take biologics, what are the biologics that they should prefer? Between secukinumab and TNF, which one should they prefer? Of course, their rheumatologists will be advocating, but they want to know if there are real differences. And the last is, of course, how long should the biologics be taken? If you can address these three questions.
Yeah, very important questions, especially in a context of a country with a lot of endemic tuberculosis cases. and a lot of exposure happening in hospitals. I still remember as a resident, we used to, you know, work long hours and just fall asleep in the ward. And a friend of mine, like we go up from during my internal medicine days, we go up from the ground floor, first floor, second floor, third floor, and the top floor is infectious disease ward. By the time you reach there, it's around 3 a.m. and you will fall asleep there. So my friend, he got tuberculosis, unfortunately. So it is the risk of exposure is very high. At least we now know that even for any biologic, if you take proper precautions, if you do a pre-start testing of tuberculosis, if the risk is high, especially almost everybody in India will have a positive tuberculin test. One thing you could do is do the quantiferon gold test, and if the risk is really high, perhaps as 𝐊𝐞𝐲 sir was speaking initially, for a few months you can give prophylaxis. The current guideline is, previously we used to start treatment after just one dose of anti-tuberculosis prophylaxis. Now the guideline is take for a month and then you can start giving the biologic. So if you want to start with any biologic, that is the way to go. Now, if I were to choose the biologic for somebody who is at high risk, I would probably choose either etanercept or IL-17 inhibitor. And these two are the drugs with the lowest risk of tuberculosis. And as far as I know, I haven't seen any report of tuberculosis in people taking IL-17 inhibitor. But in India, the experience may be different. But at least in the West, there is no such report.
And how long do you take the biologics once they start?
Yeah, it is a difficult question to answer. It depends on a lot of things. One is when you start the treatment. The second is how you respond to the treatment. And the third thing is for anybody, you don't just stop the drug. For example, if you're taking, let's say, adalimumab, you're taking it every 2 weeks. You take it for a year. What I generally look at is the past 6 months. If there is absolutely no flare, if there is no pain, no stiffness, nothing at all, then I start making every 2 weeks, every 3 weeks. And then you start increasing the gap between the injections. And then when you feel really comfortable, you stop. I have somebody who takes infliximab once every 4 months. If you go to 5 months, the patient will flare. So some people can stop it. Some people can take very low doses.
ओके, तो डॉक्टर साहब ने कहा है कि पहला कि टीबी अगर आपको चांस है तो एक टीएनएफ इनहिबिटर इटानरसेप करके आता है, उसको प्रेफर किया जाता है, या सेक्यूकिनुमैब जो IL-17 इनहिबिटर है, इन दोनों में टीबी का चांस बहुत कम है. डॉक्टर साहब ने एक भी केस नहीं देखा है सेक्यूकिनुमैब में. हमारी कंट्री में टीबी रैम्पेंट है, हम लोगों में एक सुषुप्त तरीके से फेफड़ों में होता है तो किसी को बाहर निकल जाता है, तो आपके डॉक्टर साहब आपको गाइड करेंगे, लेकिन ये 2 ड्रग्स ली जा सकती है. सेकंड थिंग इज कि कब तक लेना है, तो वो मुश्किल सवाल है, लेकिन जिन लोगों को डॉक्टर साहब कहना है कि अगर 6 महीने बिल्कुल रेमिशन बने, बिल्कुल बीमारी एक्टिव नहीं है, उनको वो कम करना शुरू कर देते हैं, और किसी पेशेंट को 3-4 महीने में एक बार भी चल जाता है, जो हम लोग यहाँ पे आमतौर पे करते ही हैं, बिकॉज यहाँ पे कॉस्टली बहुत पड़ता है. तो दैट इज वन थिंग दैट ही सेड कि सबको जिंदगी भर लेने की जरूरत नहीं होती, लेकिन बंद करना भी बहुत मुश्किल होता है, जनरली चालू रखना पड़ता है. और तीसरा, बिटवीन सेक्यूकिनुमैब एंड टीएनएफ, जैसे इन्होंने बताया कि दोनों वैसे सेम ही है, लेकिन अगर आपको टीबी वगैरह ज्यादा है तो IL-17 प्रेफर कर सकते हो. तो ये मेजर बातें इसके बारे में हुई. Professor 𝐊𝐞𝐲, there are some questions on COVID and ankylosing, and people are curious. One of them who has been advocated was on infliximab, had to the rheumatologist asked to stop the infliximab because of the fear of COVID. So what are your comments on COVID and ankylosing and the treatment part?
Right. Interestingly, for our rheumatology patients, the COVID are less, because in our department we are seeing really less amounts of COVID infection in patients who are regularly either rheumatoid, systemic lupus, scleroderma, MCT, like that one. That's a fortunate for our patient population. Regarding biologics vis-a-vis COVID, so this is an issue which is really needs to be addressed regularly with scientific inputs, right? As we know, as we have discussed, as all the literatures are coming and all the inputs are coming, that it's an immunocompromised state, more prone to have infection. So if you need to go regularly to expose ourselves to the society where there is a chance of acquiring COVID, and it's an asymptomatic COVID as is being discussed regularly. So if you need to take regular TNF inhibitor, that's an issue. It needs to be compromised. Otherwise, if we don't have to go regular outside visits, or if you can restrict our visits, so that TNF inhibition can be taken can regularly, as we have discussed. If you can expand the intervention, like if instead of 2 monthly TNF inhibitor, if we can expand this to 4-month gap or 3 months gap, something like that, majority of patients can manage with that one. With NSAID in between, we take regular exercise, avoiding stopping of smoking. By that way, if you can manage TNF inhibitor in the setting of angstrom, that would be an ideal one. So, but it's to be taken care, because the patient who is taking requiring regular TNF inhibitor, and in this era of COVID infection, that needs to be balanced.
तो डॉक्टर साहब, प्रोफेसर साहब का कहना है कि आपको जस्ट बिकॉज यू आर ऑन दीज मेडिसिन और एंकलोजिंग है तो आपको कोई कोरोना का चांस ज्यादा नहीं है, उतना ही चांस है जितना हमें भी है। लेकिन अगर आपको होता है कोविड, जो देखा गया है वो ये है कि जिन पेशेंट्स को इन्फ्लिक्सिमैब और ये सब दवाइयां चल रही थी, उनको एक्चुअली कोविड की कॉम्प्लिकेशंस कई पेशेंट्स को कम हुए हैं, स्पेशली जो एम्बुलेटरी थे उनको ज्यादा प्रॉब्लम नहीं हुई है, बिकॉज कोविड में जो इम्यून रिस्पॉन्स है वो प्रॉब्लम कर रहा है मरीज को ज्यादा। लेकिन आपको अगर हो गया और आपको दवाइयां चल रही है तो बेस्ट है कि आपके रूमेटोलॉजिस्ट को कंसल्ट करें। और बाकी सब पेशेंट्स को अगर बीमारी शांत है, माइल्ड है, तो जो इन्फ्लिक्सिमैब या ये सब इन्फ्यूजन जो इंजेक्शन उसका प्रोलॉन्ग किया जा सकता है, बजाय 2 हफ्ते के 3 हफ्ते 4 हफ्ते ऐसा भी आप कर सकते हो। आपके डॉक्टर साहब आपको गाइड करेंगे, लेकिन ज्यादा प्रॉब्लम्स नहीं है इसमें, ज्यादा परेशान होने की जरूरत नहीं है। आपको हो तो तुरंत आपके रूमेटोलॉजिस्ट को संपर्क करिए अगर आप इन मेडिसिन पे हो। दैट इज द शॉर्ट आंसर टू दैट। Nigel, I think this will be the last part because there are so many questions that we cannot address and we are moving towards the end. So I will just ask the last questions, set of questions to Nigel. That surgery ke baad, people have asked a lot of questions on surgery, and they have asked me in my own chamber also sometimes that are there any surgeries for the spine or for the cervical spine which can sort of rectify these problems or even cure it? That is what they are asking. I know there is no cure, but are there any surgery which can be done on these patients? And if so, when should they be subjected to these kind of surgery? What are the chances of complications?
Yeah, surgery is generally considered sort of a last resort for very advanced disease. First of all, we should understand surgery is only structural modification. It doesn't control the disease. So surgery का role ये है कि अगर if the neck is too bent forward and you cannot see forward, for example, अब चलने के टाइम पे अगर हम आप आगे के रोड नहीं देख सकते हैं, ऐसा बहुत advanced disease है, तो surgery का role है. Otherwise, surgery generally doesn't have much of a role in ankylosing spondylitis. We have 1500 से अधिक पेशेंट्स है हमारे यहाँ, लेकिन साल में हो सकता है 4 या 5 मरीजों को ऐसे सर्जरी होता है. So it is very, very, very rare to do surgery for ankylosing spondylitis. What essentially is done is if the spine is bent like this, a little piece is broken here, and then you make it a little straight so that you can see forward. आगे देखने के लिए थोड़ा सा मदद करे, बस इतना ही है.
हाँ, तो जैसे डॉक्टर साहब ने हिंदी में ही बताया है कि जिन मरीजों को इतना बेंट है कि देख भी नहीं सकते हैं सामने, उन्हीं के लिए सिर्फ सर्जरी एडवाइसेबल है, क्योंकि उनको एक्सीडेंट का चांस बहुत ज़्यादा हो जाता है. वरना सर्जरी का ज़्यादा रोल एंकलोजिंग स्पॉन्डिलाइटिस में अनफॉर्चुनेटली नहीं है, और क्योर तो बिल्कुल ही नहीं करता हो. जब हमारी दवाएं भी नहीं करती तो ये तो मुश्किल है. Is madam around? Amita madam, I cannot see her any longer if she's left here.
She, I think, stopped the camera, but she is around.
I wanted her to.
Yes, yes.
So there has been this one question on sulfasalazine, which has been, and I'll just take that up myself. कि sulfasalazine, तो sulfasalazine very important drug, बहुत काम की दवाई है. पेरिफेरल आर्थराइटिस, अगर आपको घुटने में, एडी में, इन सब जगह में पेन है, हाथों में, तो उसका रोल ज्यादा है. और एक बार वो शुरू करें तो उनको लगातार लेना पड़ता है. सेफ दवाई है, प्रेगनेंसी में भी अप्रूव्ड है. There was a question on pregnancy and ankylosing also. So
Madam is there, madam.
So I can take up.
Yeah, madam can take it.
Yeah, you want pregnancy and angst-fond. Pregnancy, देखो angst-fond में pregnancy होने में कोई problem नहीं है, ना ही आपका fertility पे कोई असर होता है, तो आपको एकदम चिंता करने का जरूरत नहीं है. मेल्स में जो सल्फासालाजिन ले रहे हैं उसमें थोड़ा स्पर्म पे असर हो सकता है, तो यदि आपको वो प्रॉब्लम है तो आप सल्फासालाजिन बंद कर सकते हैं, और वो रिवर्सिबल होता है मोस्टली केसेस में, उसकी भी कोई चिंता की बात नहीं है. सिर्फ एक इशू आता है यदि लेडीज को एंकिलोजिंग स्पॉन्डिलाइटिस है और उनको हिप का जो हिप जॉइंट में प्रभाव है तो नॉर्मल लेबर में प्रॉब्लम हो सकता है, उनके लिए सिजेरियन सेक्शन करना पड़ सकता है। बाकी एंकिलोजिंग स्पॉन्डिलाइटिस बीमारी का कोई भी प्रॉब्लम नहीं है। तो ये कोई भी जो चाहता है कि उसको बच्चा चाहिए, सबको हो सकता है एकदम।
And regarding sulfasalazine, madam, you want to say that?
सल्फासालाजीन का रोल सिर्फ यदि आपके और जोड़ों में प्रभाव है, स्पाइन के लिए सल्फासालाजीन का कोई ज्यादा रोल नहीं है। हमारे देश में दे रहे हैं क्योंकि हमारे बहुत सारे मरीज एंटी टीएनएफ नहीं ले सकते हैं, बायोलॉजिक बहुत महंगा है, और मैं तो गरीब देश उत्तर प्रदेश में काम करती हूँ, वहाँ बहुत मरीजों के पास इतना पैसा नहीं है ये सब दवाई लेने के लिए, और ना ही हमारी गवर्नमेंट फ्री देती है। तो इसीलिए हम एज ए डेस्परेट मेजर ट्राई करते हैं सल्फासालाजीन देना उनको, बट बहुत ज्यादा काम नहीं करती है। पर कुछ मरीजों में फायदा हो जाता है, तो जिनको फायदा हो जाता है वो बहुत खुश है, वो लेते रहते हैं, कई सालों लेते रहते हैं, और धीरे धीरे उनका डोज 3 ग्राम से 2 ग्राम, 2 ग्राम से 1 ग्राम, और वो लोग खुश रहते हैं उस पर, तो अच्छा है। पर वो 10 से 15% मरीज ही होते हैं, ज्यादा नहीं होते हैं, तो इसलिए हमको बहुत ज्यादा उसके ऊपर निर्भर नहीं होना चाहिए।
Thank you, madam. So this is very on Guru Purnima. We have our teacher, both teachers, Professor 𝐊𝐞𝐲 and madam there. So great. Ami, I think now you can run with the video, and then after the video, we'll have a vote of thanks from.
Question. Can we have just one question?
Yeah, you have a question, please ask.
Yeah, I just have one question. When you say that medication should be started early, then it should be NSAID early or biological early. The flowchart suggests that NSAID should be the first line of treatment. But in all the slides, we are talking about starting biologic early. So it is a bit...
There's no slide, so you take it.
The first line of treatment is always NSAIDs, because that is the easiest to give, that is the cheapest, everybody can take it, and also it's quite a safe drug in the right setting. And you get to know the results within 2 to 4 weeks, right? And if you don't respond to NSAIDs in 2 to 4 weeks, there is no point in pushing it further. You have to go to the biologic early on. The evidence for preventing progression is there only with the biologics as of now. So do we have evidence of anti-inflammatories preventing progression in less than 5 years, 5 to 10 years? We don't have that kind of data. It may be that is also the case. If we start NSAIDs much earlier, it may have a disease modifying potential, but we don't have the data for that.
प्रोफेसर साहब का कहना है कि फर्स्ट लाइन ट्रीटमेंट तो NSAIDs ही होनी चाहिए, और 2-4 हफ्ते देने के बाद अगर रिस्पांस नहीं मिलता है तो फिर जल्दी बायोलॉजिक्स जो अफोर्ड कर सकते हैं उनमें शुरू करनी चाहिए, ताकि लॉन्ग टर्म जो है वो डेटा ज़्यादा बायोलॉजिक्स का है कि वो बीमारी रोकती हैं। हो सकता है पेन किलर्स का भी वही डेटा हो अगर आप जल्दी शुरू करते हो तो आई थिंक वो भी आपके रूमेटोलॉजिस्ट, हमारे यहाँ तो मेनली तो NSAIDs ही देना पड़ता है बिकॉज नॉट मेनी कैन अफोर्ड, सो एनीवे वी गो बाय दैट रूल, लेकिन फर्स्ट दवाई तो पेन किलर्स ही हैं। That to answer your question, Ami. Okay, the rest of the question, there are lots of questions. I would request you to note them down, Ami, and we will get back to them on email or in some way, because we should get back to them.
We will get back to them by email, because majority of the people have registered with us. Right. So we will definitely get them. Now I would like to call Mr. Ashish Joshi. He will like to share about Antardhwani.
Hi, all of you. Thank you so much. First of all, most importantly, thank you to all the patients. The kind of response that we had, it was all because of you. We could actually do the session. As Dr. Sapan sir always say, this is a group which is run by the patients, run for the patients. आपका group है, आपने आपके लिए चलाया हुआ group है. तो I mean, we are more than happy always to have all of you together here. बहुत मजा आया ये पूरा session में. Nijil sir, amount of time that you spent here with us, the kind of wisdom that you shared, I mean, it is really tremendous. I can see the responses here on our log, the way the people are happy, the way they are actually enjoying this entire thing. We are sincerely thankful to all of you, Dr. 𝐊𝐞𝐲 sir and Dr. Agarwal, Amita ma'am. We always had this on our wish list that, you two should be part of our session. I mean, Sapan sir can vouch for it. We always have been trying to catch hold of you, but somehow, I mean, we were falling behind. We never had the right kind of a session, and you being here is really great. I mean, we cannot put it in the right words. To summarize this, it is an effort which we started only because of the motivation of Dr. Sapan Pandya. I mean, 6 years ago, we started this entire initiation. We are very happy that we have got about 2,000 patients who are here. अंतर्ध्वनि करता क्या है? तो अंतर्ध्वनि सभी पेशेंट्स को इकट्ठा एक प्लेटफॉर्म देना चाहता है जहाँ पे पेशेंट्स एक दूसरे के साथ बात करें, एक दूसरे के साथ एक्सपीरियंसेस शेयर करें, और जैसे कि ये अभी का सेशन है उस तरीके से बहुत ज्यादा सेशंस हो जिससे वो और ज्यादा नॉलेज गेन कर पाए और ज्यादा इंटरैक्टिविटी बढ़े. ये सबसे ज्यादा इंपॉर्टेंट चीज हम करना चाहते हैं. अलॉन्ग विथ इट हम लोग बहुत सारा रिसर्च एक्टिविटीज अभी शुरू कर चुके हैं. सपन सर ने हमको एक स्पेसिफिक गाइडलाइन बना के दी थी कि योगा को हम किस तरीके से इंटीग्रेट कर सकते हैं एज अ राइट एक्सरसाइज फॉर ऑल द एंकिलोसिंग स्पॉन्डिलाइटिस पेशेंट्स एंड हाउ वी वुड बी एबल टू गेट द राइट काइंड ऑफ रिजल्ट. तो एक बैंगलोर की संस्था है एस व्यासा करके, उन्होंने सर के गाइडेंस के थ्रू एक स्पेसिफिक टेस्ट कंडक्ट करी है फॉर द पेशेंट्स. Now we have got two groups जहाँ पे लोग योगा कर रहे हैं और योगा नहीं कर रहे हैं, and then there is going to be a result out of it. So there are about 60 patients who are doing this, and I'm sure we would be doing this again and again, and there would be more results coming through out of this. There are a couple of more research projects that we are going to get engaged into. See, I can keep on talking about what Antardhwani wants to do. What is really encouraging is the number of patients that have gathered together. And what is more encouraging is the kind of engagement and the kind of questions which are coming through, which is really, really very interesting and very engaging. Once again, thank you so much. Antardhwani is your platform. ये आपका platform है. आपको सबसे ज़्यादा benefit Antardhwani से मिले, इसीलिए ये platform है. आप जब चाहे, you can reach out to us. We would be continuing with this kind of sessions with the help of all the eminent doctors who are here there with us on our panel. We are really very thankful. Today we are in Gujarat, actively available, but we are sure we would be active all across India pretty soon, and definitely we'll see each other post-COVID on one-on-one basis. Thank you so much once again. Thank you, Sapan sir.
It's really humbling to see all the patients who have logged in, and some are from wheelchairs, some are from their beds, and it's just amazing and so humbling.
It is.
Praneet sir would like to share a few things. Praneet sir?
No, just thanks you, Dr. Nijil, Dr. 𝐊𝐞𝐲, Dr. Sapan, all the patients. आप लोग, I mean, definitely it was very engaging, very informative session, and thank you for giving time. And I hope आप सभी लोग को इससे फायदा हुआ होगा, सारे patients को इससे, and appreciate, and hopefully we can again connect soon. Thank you.
Thank you, Praneet sir. I would like to thank Dr. Nijil, Dr. 𝐊𝐞𝐲 for giving wonderful insights during the session, and Dr. Sapan Pandya for constant guidance. A big thank you to all the participants for joining the session. For any updates related to ankylosing spondylitis, please log into our social media pages or get connected with us on contact@antardhwani.org. You can WhatsApp us, message us, or you can call us on 990-990-3966 anytime. Any question is most welcome from any of you. Thank you.